Okay, so in this video, this is going to go over insulin requirements for the management of new onset type 1 diabetes. And the important thing to appreciate is at the end of the day, type 1 diabetes is an autoimmune condition whereby the body is unable to functionally create insulin anymore from the beta islet cells in the pancreas to manage blood glucose levels. So essentially, the body is without insulin. And because of that, we need to provide exogenous insulin in order to mimic what the pancreatic function is. And the ways that we mimic and safely mimic the pancreatic secretion of insulin is what we'll be going over today. So to understand what the pancreas is doing, we kind of have to understand what kinds of sugar or glucose sources we are introducing into our blood. And the two biggest categories of things that are introducing sugar or glucose into our blood is food in the form of carbohydrates, as well as the second group is our liver in the form of glycogenolysis or gluconeogenesis. So both of these processes allow for the body to consistently give a stable amount of trickle glucose into our blood, basically, whereas the food give strong spikes or boluses of carbohydrates into our body. And our pancreas functions to manage both of these. So the insulin provided by the pancreas both is like in a trickle amount to cover for the liver's function of constantly giving slow little bits of glucose into our blood. And then the pancreas also has moments where it boluses or has a large amount of insulin spike in order to account for the extra glucose that's introduced from our diet. So in the absence of the pancreas's function, we have to both cover for this trickle amount as well as the bolus amount of insulin. This trickle amount is done with the long-acting insulin, and the boluses are done with short-acting insulin. So for down here, I've kind of tried to draw out a little easy graph of blood glucose versus time. And if we think about it, having the liver constantly give a trickle amount of glucose into our blood would kind of show that, for example, if we started off with 100 milligrams per deciliter of glucose, which is like a normal level, ideal in the body, if the pancreas is also working to provide the insulin, it should stay roughly at this normal level. But in the absence of the pancreas, the liver's contribution of glucose will slowly raise the glucose level over time, and then eventually we'll be very off of where we want to be normally. Same thing with food. If we were to account for just the food that was given, for example, let's say we eat at breakfast, we eat at lunch, and we eat at dinner. If we just look at the food contribution to our glucose levels, we would, of course, just be hanging out at a normal level until they eat, and then it will go up quite a bit, kind of stay the same, eat, go up, and then eat again, and then go up. So the cumulative effect of both the liver and the food that we eat would kind of look like this, where it's upsloping because of the gluconeogenesis and glycogenolysis. It would bolus up because of the food, and then it will still keep creeping up because of the liver contribution, bolus again, and then liver contribution, food again, and then liver contribution. So what ends up happening is that we're fairly far away from where we started off, where we want to be, and then this level of hyperglycemia can cause issues in terms of like polyuria, polydipsia, electrolyte abnormalities, and we can kind of go over those things in another video, but lots of issues that come to play because of hyperglycemia. Also, as an aside note, which we won't really be talking about too much, in the absence of insulin, the body thinks that it's going to be in a state of starvation and will switch on the ketosis process, which can lead to a dangerous condition called diabetic ketoacidosis. And that's why in a setting of no good pancreatic islet cell insulin secretion, we need to have at least one of these players constantly acting in order to switch off the ketosis mechanism so that they don't get into this dangerous condition of DKA. So next we'll learn how to calculate the basal or long-acting insulin required to cover for the liver, and as well as the bolus amounts, the extra spikes of insulin we need to cover for the individual meals in order to attain the goal of remaining at a normal glucose level throughout the day, despite these contributors of the liver and the different foods. So to understand the calculation behind all of this, we have to understand where some of the assumptions are made. So one of the assumptions that's made is that a safe level of insulin to start off with to cover for both of these in a given day for an individual is somewhere between 0.5 to 1 unit of insulin per kilogram body weight per day. This is something that was kind of empirically derived and has found to be a safe range to both control the glucose better than not having any insulin at all, but not so much so that it would tank the glucose down, because that's one of the big things that we would want to try to avoid. We want to a little bit underestimate almost the amount of insulin needed and tweak things later than to try to absolutely nail the blood glucose control on the first try and risk going hypoglycemic, because hypoglycemia is very dangerous. You can die from that. The next thing to note is some of the calculations and formulas we're going to be doing is based off of the assumption that people tend to eat a 2,000 kilocalorie diet at a normal basis. And we also estimate that about 50% of that 2,000 calorie diet comes from carbohydrates, which essentially means that about 1,000 kilocalories of carbs are eaten in a day. And if we were to use the conversion factor of 4 kilocalories are in 1 gram of carbs, then we can see that if we divide this by 4, we can see that about 250 grams of carbs are consumed in a day for an average person. The other thing to note is that we've determined that roughly the amount of carbohydrate contribution into our blood is 50-50 between our diet and our liver. So if we have determined that roughly about 250 grams of carbs is consumed by a person in a day, the liver contribution of carbohydrates is also about 250 grams. What that means is total, we have about 500 grams of carbs to deal with throughout the day that we need to be covering with insulin. So from here, I'm going to jump into an example because I think it'll be easier to illustrate how the thought process and calculation goes by having an example. So let's say we have a 30 kilogram child who is experiencing new onset diabetes, and we're suspecting that this is type 1 diabetes, and we need to find out what an appropriate insulin regimen is for him or her to safely bring down the glucose, but not so much so that he'll become hypoglycemic. So let's say we try to go on the conservative side of things and we estimate that this person's daily insulin requirement is about 0.5 units of insulin per kilogram body weight per day. That means if we have a 30 kilogram child, that is 0.5 units of insulin per kilogram per day times 30 kilograms, which would take us to about 15 units of total insulin in a day. And we had just talked about how about half of the carbohydrate contribution in a day is provided by our liver, which we want to cover with long-acting basal insulin. So we reserve about half of the insulin for the long-acting insulin. This, for example, will be like glargine. And then the other half will be set aside for meals. Now, in adults in type 2 diabetes management, you'll often see that this is just divided into equal threes for the three meals. So, for example, 2.5, 2.5, and 2.5 units for breakfast, lunch, and dinner, and then do any adjustments with something called a sliding scale of insulin. But in type 1 diabetes, especially in children, we do a little bit more careful monitoring of the type of insulin we give, because if we happen to eat a little bit less or eat more, giving the same amount of insulin for less or more meals can be kind of dangerous. If we eat less and we give too much insulin for the amount they ate, that will tank their blood sugar. Conversely, if they eat a lot more than what they were typically quote unquote supposed to, giving the usual amount of insulin may lead them to still be very, very hyperglycemic and have very poor control. So we actually use something called the carb ratio and the correction factor to address these things. So let's keep going with the example of a 30 kilogram child, and we're using the total daily insulin of about 0.5 units per kilogram per day. We determined from the previous calculation that about 7.5 units of long-acting insulin is appropriate to cover for the liver. So let's say this person is not eating anything. So we started off with, let's imagine we started off with a normal 100 milligram per deciliter glucose, let's just say, right? And we gave this person a shot of 7.5 units of long-acting insulin to cover for the liver. Theoretically, it should be completely flat. And as long as the patient doesn't eat anything, it would stay roughly around here and stay flat. Now, of course, that's not what exactly happens. They have to, of course, eat breakfast, lunch, and dinner. So what happens is, if they stay completely fine right until they eat, and it's going to go up. Now, it's going to stay up again here if we don't give an extra amount of insulin to bring this down. That's where the carbohydrate ratio comes in, or the carb ratio. So the carb ratio is a ratio between the amount of carbohydrates that 1 unit of insulin would cover for. So, for example, it's calculated by taking the total daily carbs divided by the total daily insulin, right? So that way you get, for 1 unit of insulin, how many carbs will that insulin account for? So the total daily carbs, as we said before, including both the liver and the food that we intake, is about 500 grams of carbs. And this is an assumption that we make for all patients, regardless of what age or anything like that. It's always starting off right around 500 grams of carbs. So you'll have to just kind of memorize that. And then the total daily insulin we calculated for this 30 kilogram person to be about 15 units. So that turns out to be roughly about 33 grams of carbs per unit insulin. If we were to round that to maybe about 35 grams of carbs per unit insulin.
Just as an aside, the reason why I overestimated the carb ratio here from 33 to 35 is so that we would be using less insulin per unit carbohydrate if we were to bring up the ratio. Essentially, it's kind of like we're estimating that 1 unit of insulin will cover for a greater amount of carbohydrates. So for the same amount of carbohydrates, we'll be using less units of insulin. That way, we lessen the chance of hypoglycemia happening.
Then we're able to use this ratio, or this carb ratio, to determine how much insulin we should give to cover for any type of meal. So let's just say conveniently this burger that this person's about to eat, or this whole meal, contains about 70 grams of carbohydrates. Then we can make sure that if we are starting off at 100 before we eat, then we can give an additional 2 units, because 70 grams of carbs divided by the carb ratio, which is 35 grams of carbs per unit insulin will give us 2 units of insulin, right? So we know that if we give 2 units of insulin here, we'll be able to successfully bring this glucose level back down to the 100 that we're hoping for. Now, in a perfect world, we would maybe see this, and if we had the absolutely correct carb ratio down on our first try, that's great. But oftentimes this, for example, this basal insulin amount is maybe a little bit underestimating how much we actually need. This also may be underestimating a little bit how much we need. So by the time when we measure our blood glucose at the very beginning before a meal, the glucose may be trending up a little bit. And our actual starting point may be somewhere around here. Let's say it's like about 150 milligrams per deciliter. Then that means, and if they're also going to eat a 70 gram of carb meal, then we have to correct for this amount that we're already above our goal. So our goal was 100, but we're already 50 above that. And we have to cover for the oncoming 70 grams of carbohydrates. That's going to bring things higher, right? So in order to account for the amount that we're already above our goal to begin with, we use something called the correction factor. Now, this correction factor is actually basically the same equation as this total carbs over total daily insulin calculation, except they use this conversion factor that takes into account that about 1 gram of carbs brings up the concentration of glucose in the blood by about 3.6 milligrams per deciliter. So that means if we were to take in about 500 grams of carbs in a day, then that would bring the glucose up in a daily basis by about 1,800 milligrams per deciliter, theoretically. So if we were to take the, how I guess we can just call it the total daily glucose concentration rise over the total daily insulin, we can get a convenient ratio that's able to tell us about how much 1 unit of insulin will bring down the glucose concentration. So if we were to, for example, have a target of 100 and we're starting off before the meal at 150 milligrams per deciliter, we're approximately 50. So 150 minus 100 of our target. So we're basically 50 milligrams per deciliter over our target. And we want to correct for that, right? Milligrams per deciliter. So what we would do is take 50 milligrams per deciliter divided by 120 milligrams per deciliter per unit insulin, which is our correction factor, to get roughly 0.4 units of insulin. So in the case here, where we have a child that's 30 kilograms eating a 70 gram of carbohydrate meal, that is 150 milligrams per deciliter glucose concentration prior to eating, we will be giving at total the coverage for the 50 extra, we're above our goal, which is 0.4 units, and the coverage for the 70 grams of carbohydrates that we take, which is the 2 units, for a total of 2.4 units. And that's how much insulin we would be giving at this time here to attempt to bring this glucose level back down to normal level. And we would do the same process over and over again for lunch and dinner to simulate what the pancreas is doing. Now, there is some practice of measuring another glucose at bedtime after we have eaten all of our meals. And again, because this is real life and we never have actually 100% perfect control over our glucose, despite having the best calculations as we can do and best estimation about the amount of carbs are in our meal. Sometimes we're going to be ending up being over the amount that we want to be. So let's say at bedtime, glucose is up here at about 250 milligrams per deciliter. Now that's not really great control overall, so we would want to kind of correct this as well. But keep in mind at this point, we're going to be going to sleep. The child is not going to be alert or awake to be able to vocalize that they may feel something weird or wrong in the case that they become hypoglycemic. We don't want to aggressively try to bring this back down to our target level. So what some people do is do something called a half correction. So what that means is that instead of trying to, let's say, for example, normal correction, our goal is, again, 100 milligrams per deciliter. So this gap here is about 150 milligrams per deciliter over our target goal. So usually what we would do is 150 divided by our correction factor of 120, which would lead to about 1.25 units of insulin. However, what we want to do is not really aggressively try to bring it back to normal. We might use a half correction factor, meaning instead of using 120 milligrams per deciliter per unit insulin, so we kind of double this to 240 milligrams per deciliter per unit insulin, and use that in our calculation to divide by 150 to essentially end up getting half of what this calculation gave us, which is 0.625 units. So instead of giving the full 1.25 units to try to bring it back down to 100, we're going to tolerate a little bit of hyperglycemia for the sake of safety and give half of it so that at least maybe it would go down to about 175, which is much better than 250, but it's a safe range to be. Oftentimes I have seen in practice that around 3 a.m. in the morning, especially if they're in the hospital, they measure another glucose just like at bedtime and do another quote unquote half correction. So not use the full correction factor, but something that is a little bit more sensitive and give half the amount of insulin that they would otherwise during the day. So to again just summarize quickly what we're doing, we want to find the basal amount of insulin for coverage of our liver, and that's done with the ratio of 0.5 to 1 units of insulin per kilogram per day. And we take half of that to dedicate towards basal. So essentially at the end of the day, we're calculating, if you want to skip this 50% portion, you can calculate the basal amount that we give, the long acting, by doing 0.25 to 0.5 units per kg per day. And to get straight to the basal / long acting insulin amount. And then for the individual intake of food, we use both the carb ratio, which is expressed in total daily carbs, which is 500 grams, divided by the total daily insulin, which we find out based off of this calculation here. And we insert it here, total daily insulin. And then because we'll be measuring the blood glucose prior to the meal as well to see how much we're off to begin with, we use the correction factor, which is the total daily glucose concentration rise, which again is used with the ratio 3.6 milligrams per deciliter per 1 gram carbs, to convert this equation into this one over the total daily insulin, so that what we're essentially doing is 1800 milligrams per deciliter over total daily insulin. I hope that was clear. If you have any questions, leave them in the comments and I'll try to get back to them. Thanks. Bye.